Good afternoon, everyone. Today I will be presenting on uncommon EGFR mutations. So there was a time when we used to be very happy just by seeing the positive EGFR report, and the treatment was pretty straightforward. But times have changed, and the EGFR mutation in itself has become very complex subject. Now we are left inquiring what exon, what mutation type, and so on. So the majority of the EGFR mutations are usually exon 19 deletions and exon 21 L858R mutations, and these are referred to as common or classical mutations. Then we have the EGFR exon 20 T790M, which usually develops as an acquired resistance to first or second generation TKIs. And then we have another subset of exon 20 insertions, which are another frequent EGFR mutations, around 10% of all, and they are resistant to classical EGFR TKIs. So less is known about the other mutations which are defined as uncommon. They comprise around 10 to 15% of all EGFR mutations, and these mutations usually show lower sensitivity to EGFR TKIs, with some exceptions being observed especially with afatinib. Unfortunately, uncommon mutations are not represented or underrepresented in most phase 3 trials comparing the EGFR TKIs either with chemotherapy or other generations of EGFR TKIs. And the available evidence on the drug sensitivity and the treatment outcomes in EGFR TKIs is also mostly retrospective. So there are no clear established guidelines with TKIs leading to the use of chemotherapy for most of the patients. So it is important that we need to define and tailor the optimal treatment strategy, and it's still an unmet medical need. Also, the incidence of detection of these uncommon mutations has increased because of the widespread use of NGS. So traditionally, EGFR mutations were grouped based on the exon number in which the mutation is detected, but that does not essentially predict the treatment responses. So in this context, we need some predictive system where we can classify these EGFR mutations, and then we can probably predict the treatment. So one such system was suggested by Robichaux et al. So they used the structural similarities and in vitro drug sensitivity to group these EGFR kinase domain mutations. And they found that this classification predicted the patient outcomes better than the traditional exon-based groups. So this is the MDACC system where they grouped into 4 subclasses. One is where we have the classical-like mutation, which is distant to the ATP binding pocket. There we have our L858R, exon 19 deletion, and also L861Q. The second is the T790M-like mutations, which is within the hydrophobic core. And then we have the exon 20 insertions. And then we have the PACC mutations, where the mutations are present within the ATP binding pocket or the C-terminal end of the alpha C helix, and where the P loop is compressed. So most of the common mutations come within the PACC group. So there is another recently published systematic review where they have grouped the EGFR uncommon mutations based on their frequency and type. So basically they group the point mutations into common and rare, and the compound mutations in combination with uncommon and common, and then uncommon exon 19 deletions. So a small note on epidemiology. So the different series have reported different incidences of uncommon EGFR mutations, mostly between 1 to 18%. So difference in incidence is mainly because of the difference in the heterogeneity of the testing methods. And also there is a Chinese series where they found that there is probably a male preponderance and more of smoking history in these uncommon mutations compared to the common EGFR mutations. So coming to the treatment activity data of these TKIs. So we know that 3 generations of TKIs have been introduced in clinical practice as the standard of care for common EGFR. But the optimal treatment for these uncommon mutations, still it is uncertain. So basically the data, whatever we have, is limited to a few prospective trials with the afatinib, that is the Lux Lung trials, 1 prospective trial with osimertinib, and we have a lot of retrospective series and case reports. So for this, we will be reviewing a recently published article in March 2024, where it is the most recent up-to-date review of the uncommon EGFR mutations, and it provides a comprehensive data on the efficacy of different drugs. So in this, finally, they evaluated 38 articles, and they had a patient population of 1,838 patients who were treated with TKI. Of these, only 4 were prospective studies, and the rest were retrospective. So these are the mutations, again, we have seen previously. They are classified into these 5 subgroups. So this is the result of the common uncommon group. So that is the G719X, L861Q, S768I, E709X, and L747X. So here, each bubble represents a response rate for a particular mutation, and it is color coded if you can see here, and the number of patients. The size of each bubble is directly proportional to the number of patients. So instead of focusing on the numbers, I would want you to get a rough idea of the response rates here for the 3 generations of TKs. After all, we are only retrospectively comparing retrospective data, but that's all we have. So here we can see that TKs, especially the second generation, they showed moderate activity in these 4 mutations, which is the G719X, S768I, L747X, and D709X. But that L861Q, it had a good response to the third generation TKs. Coming to compound mutations, both second and third generation TKs showed activity, and also when they compared the compound mutations with single mutation responses, they found that probably compound mutations had a slightly better response rate compared to single mutations, probably because of the classical mutations which are present, which are actually driving the tumor. So these were the response rates to the exon 19 deletion insertions, but the data is predominantly for the 747 to 750 deletion insertions. So whether we can extrapolate it to other exon 19 deletion insertions is a question. Also, they also grouped this mutation. Initially, we saw one classification, the MDSCC classification. So these mutations again were classified based on that system. And here they found that they were able to be grouped into 2 groups. So when they grouped the mutations, they found that the mutations which were classical-like mutations, they had a better response rate with the third generation TKI, that is osimertinib. And mutations which were like the PACC mutations, they had better response rates to second generation TKIs. So this is we also have the results from the Achilles trial, which were recently presented at the ESMO Congress 2023. So this is the first randomized phase 3 trial in uncommon EGFR mutations, where they compared afatinib versus platinum pemetrexed chemotherapy. So they included all sensitizing uncommon mutations, excluding exon 20 insertions and de novo T790M insertions, mutations, sorry. So around 109 patients were randomized in a 2:1 randomization, 73 to afatinib and 36 to the platinum doublet. Also, the most common mutation here was G719X followed by L861Q. So the study met its primary endpoint of PFS, with the PFS being 10.6 months versus 5.7 months for afatinib and chemotherapy arms, respectively, with a hazard ratio of 0.422 and statistically significant p-value. If you look at the response rates also, the response rates were good, with afatinib having a higher response rate of around 61% compared to 47% with chemotherapy. So to summarize, the incidence of uncommon as well as compound EGFR mutations is rising, probably due to the increased adoption of NGS testing platforms. These mutations have a lower response rates to TKIs compared to common mutations. Structure-based classification may guide treatment decisions rather than exon-based classification, just as we saw here. Second-generation TKIs, especially afatinib, have shown significant clinical activity, especially in the PACC type mutations and the 4 mutations which have been mentioned here. And classic-like mutations and L861Q, they have shown better responses with third-generation TKIs. The only phase 3 RCT we have in uncommon EGFR is with afatinib only, and it has met its primary endpoint of PFS. So final thoughts, what we probably need to do is we need to adopt NGS testing more often. We need to make it a standard practice both in tissue and liquid biopsy. And it is practically not possible to remember all the binding patterns to EGFR mutations. So it is important to take the support of molecular oncologists, geneticists, and have a molecular tumor board discussion. Experts also suggest in vivo testing, since the responses to TKS can be pretty quick. So if you have a doubt whether the drug is working or not, so probably we can use the drug, maybe get a scan in a couple of weeks or 4 weeks to see if the patient is responding, and then probably we can commit the patient to a longer duration of the drug in between the scans. And also we have resources, website resources like Uncommon EGFR Mutations.com, where they have pooled a database of uncommon mutations, and they have made available individual patient data also, which can help us guide treatment decisions. Thank you.